Hello, I'm David Kerr, Professor of Cancer Medicine from University in Oxford. I'd like to talk today a little about a rather provocative article that was published recently in the New England Journal of Medicine. Now, it had a rather strong focus on the American healthcare system, as is so often the case with the New England Journal. But I think there are broader lessons that we might learn and that we might apply to how we deliver cancer care in low, middle, and of course high income countries. The article was around a particular set of circumstances as to how wider medical care is delivered in the United States and their insurance system of delivering it. And it's called step therapy, and how they're currently pushing through legislation around safe step care. Interesting juxtaposition of words. Step therapy, it's a utilisation management strategy where insurers, or those who are in control of paying for healthcare, implement tiered treatment pathways. So what happens is that patients and their physicians need to seek approval for restricted, i.e. expensive therapies, but they can only do this if they've documented that there has been, that they've tried the various different levels of, if you like, simpler treatments before they can apply for, and one would imagine be granted, access to the expensive medicine. Of course, all of this, these sorts of management practices stem from the fact that as a society, we've just been unable to deal with how we provide wider access to innovative, expensive medicines. We do it in the United Kingdom in our socialised healthcare system using a health technology assessment group called NICE, in which we make a value proposition. We look at the cost effectiveness, the benefits of new drugs, and we put that into a transparent model that allows us to work out relative cost effectiveness so that we can compare the benefits, disbenefits of cancer drugs versus hip replacements versus new imaging technologies versus new medical devices. So we can speak a common language and compare the societal benefits of each of these different interventions one to the other. Step therapy is interesting though, and if one were to be assured that we could link step therapy to evidence-based guidelines, I don't see a problem with that at all, nor do the authors of the New England Journal, nor do the authors of this article in the New England Journal of Medicine. We would argue that step therapy could promote improved quality of care when it's used to steer patients towards evidence-based medicine, guideline-associated treatment. One of the problems that they've found, though, is that when they've looked at the payment structure and how access to these restricted expensive medicines works, not only cancer care, this is across all of medicine, what they've found is that in as much as a third of cases, the tiered steps don't seem to map onto evidence-based guidelines at all. So that, again, that may be a particular problem of the sometimes perverse incentives in the American healthcare system. But the idea about tiering different steps and levels of treatment seems sensible to me, and I think could work very well. What's interesting, though, is that the article in the journal talks about this new legislation around safe stepped medicine. So are there variations to step care that should be legislated for that would protect the rights of the individual patient, their human rights, if you like? And there were some quite interesting exceptions that have been built into this legislation. One is to be able to demonstrate that the required treatments have previously been ineffective. So that's one exception. Another is that delay of effective treatment would lead to severe or irreversible consequences. Therefore, that would protect patients from harmful delays. This seems a no-brainer, but they've had to legislate for it. Required treatments are contraindicated. That, of course, would promote patient safety. just drug labeling would offer an established way for identifying contraindications. One would have thought that the physicians would have been aware of those in the first case. The required treatments would prevent the patient from performing normal occupational responsibilities or activities of daily living, and therefore would promote the patient's quality of life. So an article that made me think about how we deliver cancer care, how we do that in a setting in which sometimes access to the very basic care is unavailable or patchy or difficult to get a hold of. But when we're seeking to try and make innovative medicines available to all strata of society, to all countries, to those who are rich and poor, the idea about thinking about this stepwise progression, which is linked to evidence-based guidelines, seems quite attractive to me. We've seen many of the important guideline groups now incorporating some element of cost into their analysis of the benefits and disbenefits of any treatment. We see that with NCCN, and we see it in ASCO guidelines. ESMO has done its own work in terms of trying to bring a financial aspect in, so that we might better understand how we can deliver innovative cancer care cost effectively and to a wider spectrum of the community of patients that we see. Have a look at the paper. I think it's thought-provoking. As I say, look beyond the immediate focus on the intricacies of the American healthcare system and consider its wider implications. And as always, I'd be really grateful for any comments or feedback that you might have. Thanks for listening as always, and for the time being, Medscapers, over and out, and thank you.